Hello, 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 everyone. It's Dr. Tamar Beckford, and welcome to the Dr. Tamar Beckford Show. I am excited today because we're going to be talking about money in healthcare. That's right. We all know that everything comes down to finances. And healthcare is no different. It's important for us to understand the ins and the outs. And I'm bringing on an expert here today who is going to do just that for us. We're going to hear all about his stories and then how he got into this. Now, this is such an important, very, very important episode. You need to record, you need to send it to your friends, you need to go back again, you need to connect everything with this particular episode. I mean, it is that important, right? So let me bring my guest on, and I don't, want to hold you guys hostage for too long. All right, so my wonderful guest, esteemed guest, I've been watching him for over 4 years now, providing information to us all. He's a graduate of the University of Illinois at Chicago College of Medicine. He did his residency in internal medicine at Johns Hopkins in Maryland. He's a former former co-founder, and chief medical officer of Compass Professional Health Services. Compass is a healthcare navigation service that grew to 1.8 members across 2,000 clients, including T-Mobile, Southwest Airlines, Chile, and the Maggiano restaurants, right? Compass was then acquired by Alight Solutions in 2018, and Alight is a 10,000 person employee benefits and HR outsourcing company. Then they separated from ION in 2017. Dr. Bricker then went on to found AHealthcareZ, which provides 400 plus healthcare financial education videos with over 200,000 views per month across all platforms. He's also the medical director of SimplePay Health, which is an alternative healthcare plan for self-funded employers. Welcome, Dr. Eric Bricker.
Hey, Dr. Beckford, thank you so much for having me.
Hey,
you're super kind to have me onto your show. So thank you so much, and thank you to your viewers.
Thank you so much for stopping by. I am excited about this episode. Like we said, we're going to be digging into the finances and why it matters. But before we get there, let's find out about Dr. Eric Bricker. Let's find out, how did Dr. Eric Bricker become Dr. Eric Bricker? What made you decide that you wanted to do medicine in the first place?
So I don't have any doctors in my family, but at the age of 16, we had a family friend who was a scientist at the National Institutes of Health, and I grew up in the town right next door to the NIH. And they have a summer internship program, and she said, "Hey, would you like to be a summer intern in our laboratory?" And I was kind of a science nerd, so I'm like, "Oh, that sounds pretty interesting." And so it was in the National Institutes of Diabetes, Digestive, and Kidney Diseases. So I did metabolism research, and it was great. And I actually did it for multiple summers. But I was kind of a people person, and the head of the lab, Dr. Joan Mackey, said, "Well, if you like science but you're more of a people person, then why don't you think about becoming a doctor?" And I said, "Oh, okay, that's interesting." And so I was pre-med in college, and then I graduated in 1998, and that's, internet boom, and they were just kind of giving away jobs for free. And every doctor I talked to said, "Whatever you do, don't become a doctor, because HMOs and the government, they're ruining the practice of medicine." And so, okay, well, let me learn about that before becoming a doctor. So I actually was a hospital revenue cycle consultant for a couple of years before going to medical school, learning about all the coding and how to bill, Medicare, Medicaid, and commercial insurance, et cetera, et cetera. So then went on to medical school and residency. And I always knew I wanted to do something sort of with the finances, because back in 1998, the finances were super messed up. And so while I was in medical school and residency, I'm like, "Oh, they'll figure all this finances stuff out, and they'll have it all
by the time I'm done."
Right, they'll have it all fixed by the time I'm out practicing. And instead of getting better, it got worse. So that's what kind of got me into it.
Oh my gosh, I love this story. I love the eternal hope and the crash that happened. But also what's so interesting about it is I love your route. So you went in understanding the financial part, and then you're like, okay, and now I'll do the clinical portion.
Yep.
But I won't have to worry about all this stuff that I went ahead and learned because they'll have it all figured out. The spaghetti will just be nice lines.
Correct.
No.
So unfortunately, it hasn't turned out that way. So I've created 400 videos to talk about it.
Oh, man. All righty. So you're there, you're in med school, internal hope, but you decide internal medicine. Out of all the different specialty, what made you choose internal medicine?
Well, so at the University of Illinois College of Medicine, it's wonderful medical school, because what they do is they actually farm you out to all different hospitals across Chicago. And so you're at an academic medical center. So the big public hospital is called Cook County in Chicago. So I did my family practice rotation at Cook County, and I did psychiatry at Illinois Masonic. I did pediatrics at Christ, which is down on the south side. And so I got to see all these different environments for practicing medicine, right? Because the type of hospital is very different. And it gives you a different sort of view. I did OB out in the suburbs, so I kind of got to see what OB in the suburbs was like. And so I did my internal medicine rotation at the West Side VA in Chicago. And it was at that point, 2002, 2003, it was mostly Vietnam era veterans. And I just loved working with them. I mean, they were awesome. They were like the coolest guys ever. And just quick side story, they would have quads, 4 patient rooms at the VA, and all the vets would like beg to be put in a quad, because they were kind of used to being in barracks.
Oh, yes.
So they got to pass the time. They could like hang out with their buddies in the quad. And so they didn't want to be in a private room. They didn't want to be in a double. They always wanted to be in a quad. So having, rounding was kind of a communal experience, because there's like no privacy. So it was a wonderful experience. And that's what really turned me on to internal medicine.
Oh, I love it. Love it. It's the people's doctor. You're able to, and being in the VA, I actually remember my experience too with our VA rotation. Ours was in East Orange, New Jersey, because I went to school in Newark. And yeah, it was just like fantastic time learning from these people who have served. So like we're serving them, but they've already served.
Oh yeah.
For us to be able to do the service. So it was really a great way to give back to those who have done so much for us. All righty. So there you are. Did internal medicine. Did you immediately from graduating from internal medicine, did you go directly into practice? Like what was the trajectory?
So while I was in my residency, I had kept in touch with one of my consulting colleagues, and he and he had become the EVP of finance for a very large hospital system here in Dallas. And so he saw how much confusion and frustration there were with patients calling in with their bills, because he was in charge of the billing department for the hospital. And I saw in residency how much confusion and their frustration there was, navigating the healthcare system. You got prior authorization, you go this specialist and that specialist, and the 2 specialists didn't talk to each other. And so I kind of understood the clinical confusion. And so we said, hey, between the 2 of us, we actually knew kind of how to hold people's hand, both clinically and financially, through being a patient. And so we said, well, why don't we start a company that does that? So we actually started our healthcare navigation firm while I was in residency. I had to get special permission from the head of the Department of Medicine to start a company in my residency. And then part of our agreement was I was going to move to Dallas as soon as my residency was done to work on the business. And this was in 2007, which of course, as everybody remembers, was the great financial crisis. And so what that means is that starting a business, we had no money. And so we basically, myself and my 2 partners, we essentially like kept our day jobs. So I worked as a hospitalist at a local hospital in Dallas. And I started Compass with my 2 partners at the same time. So I was a practicing physician in the community for several years before Compass grew so much that I'm married, and at that point I had 2 small children. And so I said, okay, well, something's got to give. So I gave up practicing at the hospital to focus on Compass and my family for full time.
Absolutely. And that's the story of a lot of people who give back, in that the beginning you're balancing both, especially those who are physician entrepreneurs. You're balancing your clinical and then this giving back, which is this business that you're building.
Yes.
And a lot of people don't realize so it's almost like Clark Kent and Superman. So by day I'm doing this, and by night I'm doing that. And
Yeah,
we're
it was
both.
not good. I tell you what, I got a lot of speeding tickets. Like I thought I was going to go to jail. Like I had so many speeding
Oh no.
tickets. So I think enough time has transpired where like my record is okay now, but it was
Yes.
bad for a while.
It was bad for going back and forth. Absolutely. Alrighty. So with starting this company, what are some of the things that you've noticed with the transition from '08 until now? Because this is now like over 10 years within healthcare, and even within the way that physicians interact with the financial portion of
Yep.
healthcare.
So it's a great question. Thank you for asking
Mhm.
that. And
Mhm.
it's really sort of a blessing and a curse, because in 2007, 2008 is right when these high deductible HSA health savings account plans started becoming more popular. So
Mhm.
when we started Compass, your typical deductible was like $250 or $500. And so
Mhm.
that went up dramatically to like 2,000 and then
Ooh.
3,000 and then like $5,000. And before, you just had office visit copays. And so you'd be like, okay, well, here's my $20 copay.
Mhm.
Or ER copay was like $50 or $75 to go to the ER. But then that went away. And so then you started paying what's referred to as the allowed amount, which is the negotiated rate between the insurance network and the doctor in the hospital. And those
Mhm.
prices are all over the map. So I was like, oh, pricing in healthcare is pretty consistent. It's $20. I'm like,
Ooh.
no, that's just the copay. That's not the actual price. And so like an office visit could be like $80 or like $480. Or like an MRI could be like $350 or $3,500. So it's hugely variable
Mhm.
prices. And now that people had these deductibles, the patients were having to pay that. And of course, a lot of the times the patient was like, I don't have that kind of money. Or the doctor would be like, well, we'll
Mhm.
just send you a bill. And they're like, okay, fine, I get my scan or whatever. And then they'd send them a bill. And like the bill, if they had like outpatient surgery, the bill would be for like $8,000. And it's like,
Mhm.
what bills do you get for $8,000? Right. It's like,
Mhm.
it's more than your mortgage payment or your rent. I mean, it's like a huge
It's a
bill.
couple months. Yeah, maybe
And
half a
so
year
it is like
worth.
it's like jaw dropping. And so that's where it is a blessing and a curse. And so it's a curse in that it really exposed people to all of these costs. And so it's
Mhm.
been like, oh, well, that's like terrible because it's hugely expensive. And like, as many people know, healthcare is the number one cause of bankruptcy in
Absolutely.
America. And
Mhm.
so, but the blessing is that it created so much pain for consumers that the 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 machinations and just the swamp between the insurance company and the doctors and the hospitals had never involved the patient before. They just paid their $20 copay, and they were never
Mhm.
in the swamp. And so
Right.
now they were in the swamp, and they were like, the swamp is terrible. And so
Yes.
now, and listen, and there have been, there's been bad behavior on the doctor and hospital side, and there's been bad behavior on the insurance company side. There's been bad behavior on both sides. And
Mhm.
so now, because people are speaking up about that bad behavior and that swampiness, then things are starting to change. And there have been changes on the insurance carrier side, and there's been changes on the doctor and the hospital side. So
Mhm.
that's why it's been a blessing and a curse.
Absolutely. Absolutely. There's a little bit more, and we won't say, I dare to use the word transparency because it's still murky.
Yeah.
We still need our ophthalmologist to help us to kind of see
Yeah.
clearly, but it is getting a little bit better.
Yep.
And those who are now, let's talk about like those who are starting companies. So I'm with a group of physicians, and we're part of RHMD, and a lot of physicians are starting their own businesses,
Mm-hmm.
and now they're looking to start self-pay,
Yep.
and which is cash paid practices,
Yep.
or some might have heard some terms, direct care
Yep.
and concierge type in
Yep.
other states. So what are some of the trends that you've noticed with that overall?
Yeah, and so it definitely has grown,
Mhm.
and which is great. And so there's a lot of physicians that actually have a sort of a combination of their revenue
Mhm.
for their practice. They might have some services that they bill to insurance and they are getting paid for by the insurance, but then they have other services that they're doing cash pay
Right.
for their patients. And there are some practices that even go 100% cash pay,
Mhm.
but that overall movement, I think, is really good, because that's where a lot of the problem with healthcare being so expensive is that it's just marked up a ton. So the
Mhm.
actual delivery of care in a lot of situations, it's actually not that expensive, but it just
Mhm.
gets marked up a ton. And
Mhm.
so if you're just doing cash pay, then you don't have to deal with the markup.
Right.
And you as a physician, you can still pay for your office and your staff and all that sort of stuff and your malpractice insurance, et cetera, but you can charge the patients much less than what they would even get through their insurance company and the hospital. And so
Mhm.
a lot of this cash pay is for people that have insurance and but they've got a $3,000 deductible. And it's like, well, shoot, I can go see the doctor and have my labs done through the doctor or whatever, and it'll cost me, $150 or $75 or whatever, and I won't even use my insurance at all. And that's
Mhm.
actually cheaper than if I used my insurance.
Exactly.
So people are going in that direction more and more. In fact, I more special, kind of start out with primary care,
Mhm.
but more specialists are starting to do this as well. So it's really growing.
Absolutely, absolutely. We've had specialists. We've even had some specialty surgeons
Yep.
who are even stepping into that movement. Alrighty. So we've talked about the good, and let's talk about the ugly.
All right.
So I'm a Clint Eastwood fan. The good,
Okay.
the bad, the ugly. So what are some of the ugly that we're seeing with a trend in healthcare, especially towards the insurances? And this is something that, and I'm asking these questions because physicians are consistently, they're starting practices, they're putting out a lot of money, taking out lots of loans,
Yeah.
and then now they're in murky waters.
Yep.
That trying to negotiate with this insurance company versus that insurance company. Am I getting the best? Should I be in this hospital group versus not in this hospital group? What are some of your thoughts on these?
Yeah, so it's a great question, and probably the financially for
Mhm.
physicians, probably one of the biggest or most impactful trends has been the growth of Medicare Advantage. So Medicare Advantage is now 51% of people who have Medicare. So
Mhm.
the sort of the term that's used by doctors and hospitals is referred to as the payer mix.
Yes.
So the doctor or the hospital, they get paid by a variety of payers. So one is Medicare,
Mhm.
another is commercial insurance, another is Medicaid, and then we
Mhm.
talked a little bit about cash pay as well.
Mhm.
So that Medicare portion is a big portion. It depends upon your specialty, but
Mhm.
sometimes it's 50%, sometimes it's 60, 70%, sometimes it's 30, 40%, right? So it
Mhm.
depends upon the type of doctor that you are, but let's just kind of split the difference and say it's about 40%. And then
Mhm.
the commercial insurance for people who have insurance through their job, they're like a police officer for the city of Houston, and the city of Houston gives them health insurance. So they don't have insurance through Medicare. They get it through the city of Houston, or they
Mhm.
get it through, they're a waiter or a waitress at a restaurant or whatever. And their insurance card says Blue Cross United Signet or whatever. So that commercial insurance for an
Mhm.
employer sponsored plan, that's about another 40%. And
Mhm.
then, so that adds up to 80%. And then typically 10% is Medicaid. And then 10% is the cash pay. So again,
Mhm.
it varies by specialty, but just kind of big picture, that's kind of the
Absolutely.
payer mix for a
Mhm.
doctor or in a hospital. Okay. Now, the Medicare 40%
Mhm.
used to be 35 percentage points of the 40% was
Mhm.
traditional Medicare, and 5% was Medicare Advantage. And now it's half and half. So 20 percentage points is Medicare Advantage and 20 percentage points is Medicare. So it's half. And the huge difference between Medicare and Medicare Advantage is that because Medicare Advantage is Medicare through an insurance company, it's not directly from the government, it's through the insurance company. And so the insurance company puts in prior authorizations. Traditional Medicare does not really have prior authorizations. You want to do an echocardiogram? You can do an echocardiogram. You want to do a knee replacement? You can do a knee replacement. You don't have to ask permission from the payer before you do it. But in Medicare Advantage, you do. And the Medicare Advantage plans not only are untimely with their prior authorizations. In other words, it takes hours to get it done. And then 2, they do a lot of denials. So even if you go and do all the right stuff or whatever, they still just don't pay. And for some Medicare Advantage plans, it's upwards of like 30% of their claims they deny, a third. And so it has become a growing problem. And there's not an easy solution for it yet. Like the state of Texas tries to do some stuff with this gold carding, and that's kind of another conversation for another day because it's kind of complicated. But I'd say that probably the ugliest thing that has really grown in the past 3 or 4 years has been the growth of Medicare Advantage and its impact on doctors in the practice of medicine.
Absolutely. And when you hear, for those who are listening, about the prior authorization, and it takes hours. Keep in mind, this is someone on the phone for hours trying to get the yes so that you can get that test done, so that you can get those medications, so that you can get that operation. Hours. Now think about an office someone is pulled away listening to music for hours.
That's right.
Trying to get this done. So you can see how it brings frustration, and it really brings on a lot of stress. So now these are some of the uglies, because these are the behind the scenes that the patient at the front don't see. They just hear, well, they said no. Well, these are some of the things that's happening behind the scenes. Now, when we even think about that, I know that you have made these videos, but what is it that brought you to start AHealthcareZ? What is it that came up?
So we sold our healthcare navigation company, Compass Professional Health Services, in 2018. And so I spent 11 years that we ran that company. I was the sales, marketing, and account management guy, along with a whole bunch of other, wonderful employees that I worked with. And so I was always outside of the office meeting with employers, and we would do open enrollment meetings with we wouldn't call them patients. They were the employees at the company. So literally I've been in like warehouses, and there was like a forklift like driving behind me and be like, let me tell you about your health insurance, or I go to a law firm, or do it virtually on a webinar or whatever, like you name it. I literally did over 200 of those. So I was always out meeting with companies and with employees and with their broker benefit consultant. And there was just still so much confusion over how healthcare worked. And they really didn't understand. And so I was like, okay, well, now I'm kind of like, I'm independent, so I can kind of give people kind of my view of how I've seen healthcare work, or rather not work. And so let me kind of take that independence as an opportunity to create these videos. And so I started doing them with a whiteboard just because I wanted to be able to do them really fast. And so I was like, okay, can I just, and like literally the amount of time it takes me to write it up there and shoot it and edit it and post it, I can do it all in about 45 minutes. And so I just wanted something where I could just, because healthcare is so complicated. I'm not going to create like really like long, complicated videos. I'm like, it's so boring. I can only give it to people like 5 or 10 minutes at a time. Otherwise, people are just not going to watch because it's awful. So I just try to give people lots of like really short snippets. And what happens is people watch them while they're drinking their coffee in the morning. That's kind of their thing. And I think that's great because the coffee keeps them awake.
Yes, it's energized.
So it's a good balance.
And it's a great way to start the day. You're starting the day informed.
There you go. Right. Because, people are like, I got a gazillion emails I got to answer, whatever. But like, they'll take a few minutes each morning to watch the video. So I post them 5 days a week.
Oh, wow. I didn't realize it was that often. Oh, interesting. Interesting. And the whiteboard, the white shirt, the dry eraser, and the tie. I connected with that.
Yeah. Well, I wear the tie because I want to dress it up a little bit, right? Because the whiteboard is kind of hokey. So I'm like, okay, I got to make it fancier.
Yes, absolutely. Alrighty. So now, you've made these videos and you started seeing an impact. What are some of the impact that you're hearing from others? What are some of the response that you've been getting to these videos?
It is, so it's, a lot of medical students watch the videos, a lot of people who are getting their masters in health administration and masters in public health. So they're going to be like healthcare administrators. A lot of them watch the videos. A lot of insurance brokers and benefit consultants that like set up the insurance plans for companies, they watch the videos. And in fact, a lot of insurance brokerages use my videos as like the training program for their new employees.
Wow.
Because they're like really busy. They're like, I can't teach you how healthcare works. Just go to AHealthcareZ and just watch these videos. And that's part of your training program. I have a lot of sort of mid-career and older doctors watch these videos. Interestingly, the largest segment, the largest industry that watches my videos are the actual health insurance companies themselves. Wow. So, which is surprising because I figured they would already know all this. So I'm not quite sure why they're watching this because it's like you already know all this. And then I also have a lot of people in government that watch my videos as well. And so it's like all people from all over the place, and they've applied it to their, because the hardest thing in healthcare is context. Because it's like an assembly line, and so you're very good at like understanding like you're part of the assembly line, but you don't know what goes on ahead of you in the assembly line or after you in the assembly line. And you're like, okay, in my little part of the assembly line, whether it's the ER or the doctor's office or doing an Excel spreadsheet for a CFO at a hospital, whatever, like you're seeing stuff on the assembly line, and it's like a disaster, right? It's like what I'm seeing on the assembly line looks like crap. Okay. It's like, why is the stuff on the assembly line so bad? And so I try to be like, okay, well, this is why on the assembly line it looks bad, because this is what's happening upstream. This is what's happening downstream. Absolutely. And so I think it helps give context for people's areas that they're working in.
And interestingly so, when you're saying those in healthcare, those insurance, even government watching videos. So you are having a larger impact, and you're probably having impact where people are making decisions based on the information, the clarity that they're getting from you, as you saying, describing why the mess is happening here, the downstream portion of it and the upstream portion. So did you, when you started making these videos, realize the impact that you'd be having?
Well, I don't know. Frankly, I don't know what the impact is, if it's large or small. But what I can say is that I really enjoy making them. So I
understand that.
It's just a lot of fun for me, because I almost look at it as like my sort of creative outlet. And it's very frankly helpful for me to have that library of videos, because I'll like forget something and I'll be like, oh yeah, I made a video about that. So I'll like watch my own video to like refresh my memory about what it is. And so I think it's just nice to have a repository, a library of that. So I tell people, just go onto YouTube and type in AHealthcareZ, and then whatever healthcare topic, like AHealthcareZ prior authorization, AHealthcareZ Medicare Advantage, AHealthcareZ ICD-10 and CPT coding. So just type AHealthcareZ and then whatever healthcare topic you want, and then the video will pop up on that particular issue.
Oh, wow. So now you've made all these videos. How did we transition from that to SimplePay Health, being the medical director?
So when we sold Compass, our CEO, Scott Shainvogel, immediately went out and started SimplePay.
He couldn't stop.
Yeah, entrepreneurs, once the out of that, it just keeps going. And so what we do at SimplePay is really an extension of what we did at Compass in terms of navigation, but it was always a challenge that we had at Compass was that we were always separate from the health insurance company.
Mm-hmm.
And so SimplePay is essentially the combination of the navigation and the insurance all in one bundle. So it's like you don't have to deal with like talking to customer service at the insurance company and talking to your healthcare navigation person, because customer service at the insurance company is your healthcare navigation person. It's one and the same.
Mm-hmm.
And so it just a lot of times one of the main issues is that whenever you talk to the doctor of the hospital and there's a problem, let's just say a problem with the bill, the doctor of the hospital like, well, it's not our fault, it's the insurance company's fault. And then you call up the insurance company and they say, well, it's not our fault, it's the doctor's and the hospital's fault. And then you're stuck. And then you're like, everybody's blaming the other person and nobody is helping me. And so the secret is really just to own the problem, to just own what the patient's problem is. It's like, half the time it's the insurance company's fault. The other half the time it's the doctor's and the hospital's fault. Like, we don't care whose fault it is. We're going to own it and we're going to fix it, regardless of where it's happening. And so to have that integrated into one thing, so you don't have to call multiple folks, just makes it a lot easier for me. Because people, I mean, it's for working age people. And as you can imagine, I mean, most of them are dealing with like families in addition to working. And like, there's just not enough hours in the day. I mean, if you talk to any working parent, like there's not enough hours in the day. Like you can barely get the lunches made for the next day anyway. Right. So to be like, look, could you just fix this? Because I don't have a minute to like, and we would get a lot of members and they would talk to us when they were like in the car, or we would hear the kids screaming in the background. I mean, it was like obvious that they were juggling all sorts of stuff.
Many things.
And so that, anyway, a long-winded answer to then how I got it. And then, SimplePay was like, hey, we need a medical director. Will you do it? I'm like, sure. Great.
I love it. Now, one of the things I'm reading about SimplePay is that it's there for self-funded employers. So is this something that was also birthed for those who are, they're starting businesses, they have employees, they are trying to find a way to provide health insurance, but they can't bring in like, this $12,000 per person that, the traditional way is. Was this also part of the thought process for this?
Yeah. So unfortunately, the way that health insurance is regulated in America, as you can imagine, is super confusing. Okay. And so
why would it be simple?
in America, health insurance is regulated largely at the state level. And so there's two main types of insurance policies. There's a fully insured insurance policy where you just pay your premium to the insurance company, and then the insurance company then pays the doctors in the hospital. And that's for companies that have like less than 200 employees. But for larger companies or organizations like the city of Houston, that have more than 200 employees, typically they're self-funded, which means that when one of their employees goes to the doctor, let's say, that police officer, and let's say his wife, they have a baby, then it's actually the employer that's paying the hospital. It's not the insurance company. And so the self-funded employers are regulated at the federal level. So SimplePay is like, look, we can sell anywhere in America because that's at the federal level. But literally, if you're a fully insured plan, you have to go to each individual state's insurance commissioner and get approval to sell SimplePay in each individual state. Wow. So that's why we sell to self-funded employers and not to fully insured employers, because we're not going to go around to 50 states and ask permission 50 times when we can just get permission for the entire country if we deal with self-funded employers.
Absolutely. Absolutely. So that makes sense. Makes a lot of sense. Reduces that music. No offense to music. Sitting on the phone listening to music.
Yeah. Well, it is, it actually hurts patients, right? Because that time, either the doctor or the nurse is spending on hold is literally time that they're not spending with a patient. And so you're like, I can't get an appointment. Well, I'd be able to see more patients or my nurses would be able to see more patients if I wasn't on hold for so long.
On
So like
hold.
it's not only stressful for the doctor and the nurse. Like we were going to interview nurses for this other telemedicine company I work for, and when we were interviewing nurses, the nurses literally said, "If I have to do prior authorizations, I don't want the job."
Yeah.
And we were like, "Shoot, we need you to do prior authorizations," and they're like, "Nope, I refuse." So it gets in the way of being able to hire folks, and it hurts patients. So it really is. And by the way, all this happened in the 90s, like with the HMOs in the 90s, all this HMO stuff with prior authorizations, like we've already gone through this like 30 years ago. Like we've already had this happen.
So we're repeating.
We're repeating it. That's exactly right. We're repeating everything from the 80s and 90s. It's just happening again. Like it literally is the exact same thing all over again.
So it worked so well then that we're going to just try it again.
That's right. What it is that, 30 years is a generation. So they're just hoping that everybody just forgot.
But then again, also, this is the generation of the quick on and off. So maybe that's another thought, right? Something is big now, and then we forget about it 2 weeks from now.
And you could do prior authorizations over the internet. Like you could do that. But the insurance companies have intentionally not. So they've got the money. They could do it. Like you shouldn't have to be on the phone, right? I mean, come on.
Absolutely.
I mean, it's the 21st century. You shouldn't have to do this on the phone. Like you should do it on the computer, right?
Yeah.
And they intentionally don't do that. They don't spend the money on it because they actually want you to wait on hold for a long time because they know you'll give up.
Tactics. Wow. I was going to ask you why, but you just really, really revealed that.
Oh yeah,
so we need
it's a very solvable problem. They choose not to solve the problem.
What are some of we know that it's solvable. From the standpoint from what you have read or you have seen, what are some of the reasons that they have said they won't do it?
They say that doctors don't have to wait on hold for very long. They say that if they don't put in prior authorization, then the physicians will do non-evidence-based tests and procedures. And the insurance company is actually saving the patient from malicious decision-making on the part of the doctor. Now, there is a kernel of truth to that.
Yes.
Because there are certainly physicians and procedures that are ordered that are not evidence-based and are not clinically justified. And so the answer is not to not have some sort of quality control process. But the point is that the quality control process should be within the healthcare organization itself. So if the physician practice or the hospital system should be like, okay, listen, so the perfect example is like cardiac stress tests. So like the cardiologists themselves are like, look, if you're an asymptomatic person, you shouldn't get a stress test. Absolutely. Like just because you're 75, that doesn't mean you should get a stress test, right? Well, what if you have high cholesterol? Still, no. If you have high cholesterol and you're 75, you still should not get a stress test. The cardiologists have come out and said that. Okay. And like there are cardiologists that are ordering stress tests on asymptomatic 75-year-olds. But the point is that the insurance company that's hundreds of miles away, that has never interacted with the patient, that has no relationship with them, they're not the ones who should be policing it. It's the physician practice and the hospital itself that should be like, Dr. Bricker, we saw that you did 8 stress tests on 75-year-olds last month that didn't need it, and you need to stop.
Right.
Okay. That it should happen within the healthcare organization, not some third party that's completely disconnected.
Hey, I love it. So now here we are. With all that you've been through, all that you've done, the different companies, have you ever experienced burnout?
Oh yeah, absolutely. And I would say that it was at its greatest during residency. And I think at a very basic level, it is a function of being sleep deprived. I mean, it is. I mean, at the end of the day, if you are a practicing physician, I mean, there are physicians that are, mid-late. I mean, they're in their 50s and 60s, and they're still, take an overnight call every fourth night, and they're still working 2 weekends a month. And so they're only getting 2 weekends a month that are like normal weekends. And then the other 2, they're working at the hospital. And so at the end of the day, they a lot of times they're married, they've got kids, they've got a lot of family responsibilities. Plus they have to do all this coverage at the hospital. And so something has to give. And what gives is sleep. Yes. And at the end of the day, like, not getting enough sleep just makes you feel terrible. It just messes with your brain. It may, little things bother you much more. You get very stressed out. You get a lot of anxiety. You get depressed. I mean, at the end of the day, just not getting enough sleep is hugely problematic. And my life dramatically improved when I just started getting more sleep.
I think one of my colleagues who's a sleep specialist will love to hear that part of the answer. It's just so important, even with executive decision making. We know its effect on the health.
Yeah, you're absolutely right.
So sleep, one big thing that you incorporated in order to reduce your stress and burnout. So organizing yourself.
That's right. If I have a choice between doing something and going to bed, like, I just go to bed.
I love it. The honesty. Yes. Alrighty. So I'm now going to ask you my fun question of the day. I have to think back to all the answers that you've had. All right. So if you weren't a doctor, you weren't doing startup in these wonderful companies, you weren't just going straight to sleep, what would you be?
I would be I'd be a journalist. Shocking. I like, the best class I ever took in high school was I was my journalism class in high school. I wrote for my high school newspaper. Miss Patrides was my high school journalism teacher. And it's just it's so important to be able to you use the word transparent, not so transparent about pricing, but transparent about everything, right? It's like the famous rule. It's like, sunlight is the best disinfectant. And so it's amazing what happens in not just, big like federal things, but also just like local government. There's some like local business or local organization or maybe a local government who's doing something they shouldn't do. Right. And you've had fantastic reporting at the Houston Chronicle has unearthed things that's and they've totally changed stuff. Like, the stuff in Houston has totally changed because the Houston Chronicle is like, guess what's going on in Houston? And they're like, well, that shouldn't be going on. And they've changed stuff as a result of that. So anyway, long-winded answer. I'd be a journalist.
A journalist. Love it. So I have this utopia. It's in my head, but a utopia nonetheless, of physicians. And you are my first journalist. I did have a photojournalist on my.
Okay.
Yeah. So they'll do the photos and then you can do.
Good. I'm going to need photos. I can't take photos very well. So good.
Absolutely. So we have the photojournalist and now we have our journalist in this utopia that's in Dr. Beckford's head with all of her doctors. I ask this question to everyone so I can figure out where am I putting you in this wonderful, magical world that we're building. Alrighty. So now with that, there are a lot of people who are watching today and they're listening and they're deciding like, wow, I want to learn more. I want to get into this person's world. What's the best way for them to either connect with you, be part of your world, or even learn and be part of Simple Health Pay?
Yeah, just connect with me on LinkedIn. I mean, you're probably watching this now on LinkedIn, so please feel free to either connect with me or follow me on LinkedIn, and then my videos will kind of show up on your feed if you do that. You can also subscribe to my AHealthcareZ YouTube channel on YouTube. And then I actually have an email newsletter. So if you go to ahealthcarez.com, then you can put in just your name and your email address, and you'll get the videos emailed to you Monday through Friday. And I don't share the email list with anybody. I don't sell it or anything like that. So you're not going to get spam as a result of giving me your email address, but either LinkedIn, YouTube, or signing up for the newsletter. That'd be the best thing to do.
Wonderful, wonderful. Well, with that, we're going to end today's wonderful conversation. Thank you so much, Dr. Eric Bricker. Thank you, those of you who are watching. And, I know some of you are saying, oh my gosh, I just jumped onto LinkedIn and there goes Dr. Beckford. As usual, I'm hearing the last of this great info. Well, have no fear. This wonderful episode will be available on our Your Caring Docs website. That's URCARINGDOCS.com. Select podcast. You see Dr. Bricker's face. Boom. Click on it, download, and send this episode to 10 of your physician colleagues, your friends who are a doctor that you hear complaining about, I don't understand. And, my payer mix is this. And you're like, oh, I heard about this payer mix thing on this wonderful podcast. Send it to that person, right? Now, if you are a physician and you'd like to be on the show, you can send me an email and we'll get you connected so that we can interview you and you can tell us about the wonderful things that you are doing inside and outside of healthcare. My last request to you is if you are looking for a dynamic speaker to speak about stress management and burnout prevention for your next event, I am she. So send me an email at drbeckford@yourcaringdocs.com. I'd love to be a speaker at your next event. With that, we are going to thank Dr. Bricker for dropping all of this wonderful knowledge and information, just one millionth of all the info that he has stored on his over 200 plus, over 400 plus videos, and over 200K people have been downloading and being a part of his world. So you can join those wonderful groups. With that, we're going to thank you for joining us, and I will see you guys next time. Thank you, everyone. Bye-bye.